Okay, well, why don't we go ahead and get started? So today I've just got some vascular cases, and really this is more just kind of almost a show and tell. So I'll show some images. You guys take a look at it, see what you think. Tell me what it is. So here's a abdominal MRA, and so this is just a standard MIP that's done in the AP projection. And then remember, as I talked about last time, with MR we get a 3D data set, so you can take it offline and you can look at it from any projection that you want. And so this is a typical reconstruction that we'll do where we rotate it by 10 degrees all the way around. So you can get a chance to look at it not just in a straight AP, but at different orientations. So what do you guys think? Do you want me to slow this down? Okay. Something draining anomalously where? Right there. Okay, so what would this be? This right here? You're talking about this right here? Okay, so yeah, so this is the abdominal aorta, so this is the right renal artery, this is the left renal artery. This actually is the left renal vein right there. Okay? So remember, so from a timing standpoint, this was probably triggered a little bit later than you ideally would have wanted to. But the challenge obviously is that the renals, oftentimes there can be pretty fast transit across, and so you can get pretty quick venous contamination. And in fact, what you'll see is there's a little bit of the renal vein, and you see a little bit of the IVC starting to fill as well, right? This right up here? Yeah. Well, so that's actually the splenic artery, right? The artery. Yeah, that's the splenic artery coming off of the celiac. Okay, so that's all normal anatomy here. But is there anything unusual? So I think Bashar commented he thought there was renal artery stenosis on which side?
On the right.
On the right. And how would you describe this stenosis? So, proximally, right at the origin. Okay. Yeah, so if you go further out, that exactly. See, if you go further out, right here is where the abnormality is. You see kind of this beaded appearance, right? So that's the primary pathology here. So what is that? Right. So that raises concern for fibromuscular dysplasia. So that exactly. So that's different than atherosclerotic renal disease, which oftentimes could be multifocal as well, but it doesn't give you this kind of classic beaded type appearance that you see. All right. So the one thing you got to be careful of with these cases, make sure you look at both renal arteries. Sometimes I've seen FMD also will affect the iliac arteries as well. So obviously you need to make sure you look at the entire vascular system in these patients. And in this person, actually, if you look down here at the, I'm not sure how well it shows up on the projector. On my screen, it shows up better. There actually is, it looks like probably a little bit of involvement down here in the external iliac as well. I don't know, can you guys appreciate that? Where it looks kind of a little bit beaded in appearance, even down here in the external iliac artery. So this is just kind of a case of fibromuscular dysplasia. So one of the things that you may come across, and again, a lot of these are pattern recognition. So here actually I gave away the diagnosis, but if you look at this, what do you see? So this is basically a arch and a carotid study, okay? Right, and so basically if we go through the basic anatomy here, so this is the arch, this first vessel here is the innominate, which then gives off the right common carotid and right subclavian. You can see a little bit of the right vertebral artery coming off here, and you can see the vertebral comes up here. Over here on the left-hand side, you can see the left common carotid and the left subclavian. And then obviously what's unusual about this is that there's kind of this long symmetric stenosis, right? So that's one of the clues, and again, this is just a rotated view where you can see that, but I think the straight AP showed it pretty nicely. So obviously, the diagnosis is already up here. This is a case of Takayasu's arteritis. So it tends to affect the aorta and the major branches. Where it's different than atherosclerotic disease is that it tends to give you long, smooth stenoses and narrowing of the arterial wall. whereas atherosclerotic disease tends to be less circumferential, less smooth, and it tends to be shorter segments, although we know atherosclerotic disease can give you long segments as well. So again, more than anything, this is just a pattern recognition issue. And then obviously these areas that are stenotic can eventually go on to develop aneurysms down the road as well. So that's one of the things you need to be aware of. So what's the abnormality here? So obviously, if you look, here's the thoracic aorta. This is the ascending aorta, the arch, and you can see this little outpouching here in the descending aorta. Right? Now, I think Dr. Nabi in one of his lectures talked about one of the normal variants, which is this ductus bump, which is just basically remnants of the ductus. But that's a little bit different than this, right? This is much more pronounced than that. I mean, it almost looks like a saccular type aneurysm here in the aortic isthmus. But this obviously is a classic location that you can develop aortic transection. And, you know, what is this? This is basically due to a sudden deceleration injury, occurs in the area of the ligamentous arteriosus, because this is the area that's prone to shearing forces. So, you know, the presentation oftentimes, you know, two ways you'll see this. One is in a patient who's in a car accident who comes in with chest pain or back pain. So an acute presentation. This case actually was one that was a chronic presentation. So the patient had a history of a car accident several years ago, but it was just never picked up at the time. But obviously this is something, once you identify this, you need to get your vascular surgeons or thoracic surgeons involved. Now obviously every single time you're not going to, if in a chronic setting like this, you may not necessarily do something about it, but I think at least you need to get surgical input on cases like this. So, okay, here's a case, and what I'm going to show you here now. So remember, one of the things we talked about in the lecture before is, what, you know, kind of the basic sets of images whenever you do a vascular study with MR is we do some morphologic images without, you know, pre-contrast. We do an MRA, which is an angiogram, and then we'll do a series of post-contrast images, which are done in equilibrium or steady state. And so these are actually ideal for imaging the venous structures because you've achieved an equilibrium, so all the arterial and venous structures should all be filled with contrast. And so this is typically done about 10 minutes after the administration of a contrast agent, and this can be done with regular gadolinium, or we can use blood pool agents like Ablavar, which basically are bound to protein, so they to albumin, so they actually stay within the blood system longer. And so at the end of each vascular study, we always will do this equilibrium phase imaging. So it's important that you always get kind of first pass imaging, which is the angiogram, and then you always get a late phase or equilibrium phase image. And then this is typically done in a straight axial orientation with a series of axial slices through the area of interest. And let me just, oops, let me see if this, let me just walk you through this. So we're starting here again inferiorly, and these are serial slices that are going up higher and higher. So what are the structures that we see at this level? So sometimes it's useful also, instead of just seeing one view, actually follow the vessels, and oftentimes that can help you to identify which vessel is which, okay? Okay, so we're at the level of the common iliac now, and you've got two vessels on each side, right? So that's, which is the artery, which is the vein? Is the one that's more, so from an orientation standpoint, this is anterior, this is posterior, okay? So is the more anterior vessel the artery, or is the more posterior vessel the artery? The arteries, so we're talking about now, this is very close to the aortic bifurcation, okay? So near the aortic bifurcation, where you're at the common iliacs, is the artery more anterior or more posterior? So think about the aorta and the IVC, right? The artery tends to actually be more anteriorly situated, right? So let's go back up to the top, okay? Maybe this is easier to see. All right, so here we are, abdominal aorta, right? and then over here is your IVC. Now watch at the bifurcation what happens. The IVC and the iliac veins typically go behind the aorta. See that, the bifurcation there? And then there's the IVC that bifurcates into the iliac veins. So the iliac veins run behind the iliac arteries, okay? So this is the iliac arteries anteriorly, and then the iliac veins are posteriorly here. And what do you see anything abnormal here, or does this look pretty normal? So again, I'll start at the bottom, and then.
Talking about arteries, or are we also talking about veins?
Wait, so you have to look at everything.
There's a filling defect in the vein.
Okay, and so if you see a filling defect, what could that be? Okay, could it be slow flow? Okay, so it looks too well defined, right? And that's the other point of this, is that when you do equilibrium phase imaging, slow flow is not going to be an issue because you're doing this 10 minutes later. So you're going to get contrast everywhere. So slow flow, so you can't attribute these artifacts to slow flow. So really, the differential here, if you see a filling defect in basically the iliac vein, right here on the right iliac vein, as well as the IVC, is what? Really, it's basically two things.
Catheter.
Okay, so I guess you're right, three things. So it could be a catheter. That would obviously be a problem. And also, would a catheter look like this? If you look at the size of this, right, most of the catheters tend to be much smaller. They tend to be much more circumferential, right? Whereas this is not quite smooth and circumferential, right? So absolutely, that's one of the things you have to think about. The other thing is, if it is a catheter, you would expect that it should go all the way out, right, to probably the femoral, because typically the insertion point is going to be the femoral veins. Whereas this thing stops abruptly, right? So I think catheter is less likely. What else could this be? So thrombus. The other thing would be a tumor, right? Obviously, I don't want to get into the details of how you distinguish between the two, but the key differentiating factor between tumor versus thrombus is the absence of contrast uptake. Okay, so whereas most tumors are going to demonstrate on late phase some contrast uptake, whereas thrombus is not. So again, this is late phase. This is equilibrium, 10, 15 minutes after the injection of contrast, and we see really no contrast uptake by this region here, suggesting in fact that this is just a thrombus. So in fact, yeah, this is just a case of IVC and iliac vein thrombus that's present. The arterial structures are otherwise pretty unremarkable. But that's why it's also important, whenever a patient's referred for, if they're referred for an abdominal study, you need to also make sure that we look at the veins as well. And this equilibrium phase imaging is good because it allows you to really be able to see both very nicely. Okay, so any questions on this case? Okay, so IVC thrombus. Okay, so here's an MRA. Okay, so again, this is done with the first pass of gadolinium contrast, and this is your thoracic aorta, and we can see all the way down to the abdominal aorta. And what do you see? What do you think of what we see here so far? So here's our ascending aorta, the arch. These are the three arch vessels, and then the descending aorta. Anything strike you so far? Okay, so it looks a little bit enlarged, and we would measure it, and we measured out, I think it was about 4.2 centimeters. So mildly enlarged, nothing that impressive. And then really, I mean, quite honestly, on just a first pass angiogram, I agree with you. That's about all you see. There's not really, the arch vessel anatomy looks otherwise pretty normal. The descending aorta and even the portions of the abdominal aorta that we see look pretty good. Notice, I'm not sure how it projects on the screen, but you can see the origin of the celiac and the origin of the SMA here. And if I rotate this, you can see the left renal artery origin and the right renal artery origin over here. So on the MRA, it's nothing really that striking or impressive. Now, here's, again, remember I said there's always three components to a study. One is pre-contrast anatomic imaging, the MRA, And then the last is some post-contrast imaging. So on this pre-contrast imaging, so this is done using a dark blood haste acquisition. So the blood is black here. And with this technique, obviously fat is going to appear bright. Blood appears dark. And let me just slow this down, and we'll just kind of go through this step by step. And we're starting inferiorly at the level of the diaphragm, and then you'll see serial cuts taking us all the way to the top of the arch. And just take a look at the structures here, and just focus again on the aorta, and tell me if there's anything at all of interest. Or nothing of interest? Okay, so you're absolutely right. The one is the wall looks thick, right? Okay. Now the issue with this, remember, with this dark blood technique, is slow flow could also give you kind of a partial signal void as well, right? So just on the basis of this alone, I think all you can say is that one, the size of the aorta probably looks a little bit bigger than what we saw in the MRA alone. This could be that there's just some mural thrombus present, or it could be that the wall of the aorta is thickened itself, right? And then, obviously, you see this most impressive, I think, in the ascending aorta, as well as even if you go up to the arch. Right? It looks like you see what looks like a little bit of thickening of the wall, but again, that could just be mural thrombus as well, right? The other interesting thing is, if I take you down here, can you guys appreciate what is this right here? Yeah, so those are the coronaries. So in fact, oftentimes you can see on just some of these straight images, because again, these are ECG gated. They're typically about 200 milliseconds in mid-diastole. Sometimes you can get a preview at least of the coronary. So it's always important to look for that. Now, I wouldn't use this to try to comment on coronary stenosis because the resolution here just isn't sufficient. But in this case, probably the most interesting finding, well, there's two findings we did. So one is we saw that abnormal area around the aorta. So we said, let's do a kind of a more specific technique. So this is what's called a T2 spin echo technique here. So this is designed to basically look for any increase in water content in the aorta. And you can see on this T2 technique, in fact, you do see high signal circumferentially in the aorta. So now this tends to make me less concerned that this is just a mural thrombus, because thrombus you wouldn't expect to have high water content. And this really, the way this looks really makes you concerned that this is within the wall of the aorta itself, raising concern that there's possibly increased water content in the aortic wall. And then if I take you to the next set of images, and these are the post-contrast images here, and again, this is done 10 plus minutes after contrast, so we're in an equilibrium phase. And what do you notice? So you can see now that there's kind of this intense hyper-enhancement of the aortic wall. Now, what you want to make sure is you don't get fooled by the fact there's always some enhancement of the aortic walls, right? Because the aorta has collagen content, and so therefore on late gadolinium imaging, you'll always see some enhancement. But here what you see is a really marked hyper-intense aortic wall. And then this finding right here, obviously, with the findings on the T2 spin echo, really are suggestive of what? Of aortitis, basically. So this is a person who looks like they have a significant inflammation of the aortic wall, leading to, or the aorta leading to a marked thickening of the aortic wall here. And this also is another case where the size of your aorta is going to be very different depending upon where you measure it. If you measure it lumen to lumen, it's a much different size than if you measure outer wall to outer wall. All right, and so this this was kind of an interesting case because this was a patient who really didn't have much in the way of symptoms, but yet had this marked inflammatory finding on his imaging. I think Bill, yes, Bill, you know this patient. So,
And his the roof. And that's part of the reason that we were, you see, he had a PET scan, which looked up, obviously, where your type is for. And now, follow-up of 3 years.
Yeah, because last time we imaged him was about 2-3 years ago. So
3 years, AI has not changed. Aortic wall is a little thinner, right? Much less uptake, and PET is much less on, initially early on some steroids, and then now an enzyme plant or drug or rheumatologist. But it was, I mean, it is a challenge because, you know, you break all the rules of where you make the aorta. You just imagine the aorta is a little bigger. And what do you do about that? And usually they are the ones that you should not touch unless really it's emergency because they're very friable. Can do anything with them. So you have to just cool it down, whichever way you can. That's really not a first case that I've seen.
but I mean, asymptomatic person. So that's that's the interesting finding. Yep. So and then there's really no right. So I mean, the workup didn't reveal anything. Yeah. So, but obviously, this is kind of the class. This is probably the most remarkable case of aortitis that we've come across. So it's, with a lot of these vascular diseases, some of it's pattern recognition. So having seen a case helps when you come across another case in the future. Okay, so here's another case. This is a 73-year-old guy who has a type 3 aortic dissection, and he's referred for an MRA to evaluate lower extremities. He's having some claudication symptoms, and the question is there disease in his lower extremities that may be causing this? So on the lower left-hand image here is just a cine image of his aorta, and you can see obviously the dissection with the dissection flap. And the area to focus on, obviously this study is really to look at his lower extremity arterial system. So this first phase here, notice you don't see, you can already see kind of the shadowing from the between the true lumen and the false lumen, because obviously the false lumen hasn't fully filled with contrast by the time that we're doing this imaging. And if you remember when I talked about last time, when you're doing a lower extremity runoff, the key is you want to image very quickly, because if you wait too long, you're going to start to get venous contamination all the way down, and then that's problematic, because especially in the lower legs, the veins run very close to the arteries and they're small vessels, so it can be very hard to tweeze out which is the artery and which is the vein. So I would say is don't pay too much attention to this phase, but if you look at these two phases here, right, so basically this is your SFA, your popliteals, and then this is your infopopliteal station. What do you guys think if you look at the MRA images here? Okay, so it looks like there's some stenosis here in the right SFA. How severe do you think it is? Yeah, yeah. I mean, it's probably not in the severe range, right? It's probably in the 50 to 70% range, right? And I'm showing it to you on a rotating basis, so you can, again, appreciate. Let me go back forward here for a second, because always it's important to make sure you look at it from multiple projections. Okay. And then otherwise, what do you think about the rest of his popliteal?
Right perineal.
Okay, so he's got right perineal that's occluded here. And then on the left side, let's see, on the perineal aneurysm. No, so that actually is, what that is just a little bit of, you notice it looks like it's outside of the vessel itself, right? This is basically just some fat that didn't get subtracted out. So I would ignore that area right there. That's just an imaging artifact. So on the basis of this, do you see anything that would say, that could explain why this person would be having claudication symptoms? Now obviously, in a patient with dissection, we would need to investigate the aorta higher up to make sure that the entire aortas or the iliacs themselves are not getting adequately fed. But let's say for the interest of time, we looked at that and that's fine. So here, I mean, other than this kind of moderate lesion in the SFA, we don't see too much. But again, this is why it's always important to make sure we look at the morphologic images and look at post-contrast imaging. So now this is, on the lower right-hand side is this, we call a vibe acquisition. And I'm starting at the bottom and working my way up. So we're starting at the feet and coming up to the calf, and now we're getting up towards the popliteal area. I don't know how well it projects on the big screen there, but do you notice anything? Anything stand out at you here? So in fact, what is this? Yeah, he's got this big, huge aneurysm, right? So he's got this huge popliteal and SFA aneurysms. And again, if I take you all the way up to the top, here the vessels look fine, right? So here we're at the common femoral, right? And as we start coming down, focus on the right side, right? Now notice the artery and the vein run very close to each other, so it can always be a little bit tricky deciphering which is which. But at this level, the artery generally runs anterior to the vein, okay? And the other way we can tell is if you just follow it up from high down, follow the vessels, you'll be able to tell which is which. But so the vessels look normal here, and then all of a sudden, as we get down to the mid-SFA, is when you start to see now this big, huge aneurysm formation right here with a large amount of thrombus, right? And so the point I think of this case is that on just an MRA, you don't see the vessel itself. All you see is the lumen. The lumen size itself look pretty preserved, right? Look pretty normal. But in fact, this can be very misleading because the story is very different than what it looks like on the MRA. So here you've actually got huge aneurysms of the SFA and the popliteal with kind of a normal or mildly enlarged lumen size. So the picture is very, very different compared to what it was without doing that. And so again, stresses the importance of making sure that you always do post-contrast imaging using a technique where you can see the entire vessel, not just the luminogram itself. Yes, Rob?
So, I guess anecdotally, I was surprised folks have had this situation where patients are brought to the lab after they've had either non-invasive CT or MRI or peripheral vascular disease. And they're brought to the lab because the patient has like classic claudication symptoms. I guess, what is your take on how good is MRA, or how good is MRI?
Yeah, so what's the sensitivity?
Well, yeah, I mean, is CAF gold standard, and how would you work these people up? Because it's really not uncommon to get either CTs or MR.
Yeah.
Let's say there's moderate stenosis patient, so classic claudication, when you do a CAF, and oh my God, it's either stenosis. So, I guess, can you comment on the various modalities?
Yeah, I mean, from a diagnostic, so I talked about that last time when we talked about lower extremity runoffs. The diagnostic accuracy for MRA and pooled data depends again on which level you're talking about. So at the aortoiliac level, it's in probably the mid 90% range. At the popliteal and femoral, SFA level, it was like 98%, and then the infrapopliteal level, the sensitivity and specificity was in the low 90s range. And the CT data also, I think, is fairly comparable. The challenge with CTs, if you have a lot of calcification, it can be hard to identify, what the true extent of stenosis is. And I'll let Sumin talk a little bit more about, the diagnostic accuracy of CT. But so in general, I think they're pretty well established. I think the infrapopliteal is a little bit more challenging because they're smaller vessels, so you start to run into resolution issues. But for the aorta, the iliac, and the femoral, you're at 90+% sensitivity and specificity. And again, all of these were done using, X-ray angiography as kind of the reference standard. No, the reason, so the reason is because the problem with So you have to localize the area. So even if, right. Right. So, I mean, the indication for doing anything for PVD is really for lifestyle-limiting claudication. So the first treatment is really exercise. Obviously, the exceptions to that is acute limb ischemia or critical limb ischemia where they have, ulcers or gangrene or things like that, or rest pain. But in the absence of that, if it's just claudication symptoms, it's really establishing the diagnosis and then medical management unless it becomes refractory. Now, the one thing, even if you're going to do an intervention, the advantage of having imaging is to know what's the approach for the intervention, because depending upon where do you start, where do you stick? I mean, do you stick right femoral, left femoral? Sometimes you have to go with the popliteal approach. So knowing the anatomy as opposed to sticking 3 or 4 times to try to get your diagnostic angiogram, I think is very helpful. So most interventionists will tell you it saves them time by having pre-procedural imaging done before they take the patient to the lab. Okay. So, so last thing I want to touch on is another potentially common indication for imaging, and these are patients that get endografts put in. So people with abdominal aortic aneurysm who get an endograft put in who now are going to need to have serial follow-up imaging done to look for complications of an endograft. So here's a case, and again, in the interest of time, I'm not showing you the MRA or the morphologic images, but I'm going to go straight to the post-contrast equilibrium imaging that we've done here. We're starting at the diaphragm and working down, and this is a patient who had a endograft put in for an infrarenal AAA. So the first question is, when you're doing follow-up of endografts, what is it that you're looking for? So one is what is it? So you're looking for endoleak, right? And then what else? So what are the things, you want to comment on whether there's an endoleak present or not, and if so, the type of endoleak, and then what else? Okay, so yeah, I mean, generally speaking, migration of these endografts are pretty unlikely to happen nowadays, aside from maybe the very acute period. So maybe on your initial imaging, make sure that the graft is placed properly. But on kind of serial follow-up imaging, it's 1, presence of endoleak, and 2, the size of the aneurysm sac, right? Because, they still have an aneurysm sac in place, and what you want to see is that the sac is not continuing to get bigger after your intervention. You want to see it stable or ideally getting smaller. And you ideally want to see that the aneurysm sac thromboses off. Okay, so in this case here, I'll walk you through this again. So let me start back up at the diaphragm, and obviously from an orientation standpoint, so here's our first vessel which is coming off, which is the celiac, and then our second vessel coming off, which is the SMA. There's my right renal artery. That vessel that runs in front of the aorta here is the left renal vein. And then here's my left renal artery. And then as I go a little bit further down, you now start to see these irregularities. And this is where the endograft is, okay?
It's good that you don't have much artifact.
Yeah, most of the endografts now don't cause much artifact at all. There's only one that's made of stainless steel, which causes a huge amount of artifact. So if you look at this, take a look at this, and what you want to focus in again, obviously, is that the stent's in the right location. Look at the aneurysm sac and look for a presence of endoleak, okay? So here we go. So now we're starting to see the aneurysm sac here, and it looks like this is all area that really has no contrast uptake, and again, in the late equilibrium phase, that suggests this is thrombosis, right? So let's keep going, and what do you see? There's something here, okay? Okay, so we've made the diagnosis that there's an endoleak present, right? Does that mean this guy needs to go back to the lab? Okay, not necessarily. So, and what is your decision making based on? Was that? Okay, so what are the types of endoleaks? Okay. I'll make it easier for you. Go ahead. Go ahead. Keep going. But type 1A or 1B is what? Proximal. But what is the basic definition of a type 1A? Right. So basically it's at the seal zone, either proximally or distally. Okay? And so as a result, this actually very nicely shows, it's almost a heat map here. So if it's more red, that suggests higher pressure. Okay? So basically type 1 is where you have high pressure because you have a communication between the aneurysm sac and the aorta itself, either proximally or distally, right? So this is a type, obviously, if you have a type 1, they need to go back to the lab, okay? Because you can't leave somebody with a type 1. Okay, so then keep going. Type 2 is what? Right, so type 2 is basically where it's retrograde flow from one of the vessels that comes off of the aneurysm sac. So you have a proper seal, but remember there's vessels that come off the aneurysm sac. So obviously the most common ones are going to be the lumbar arteries that come off posteriorly, but also keep in mind that you also have vessels coming off anteriorly as well, right? Now in the infrarenal aorta, what vessels are there besides lumbars coming off the aorta? Right, the IMA is only one. If you're higher up, obviously you've got the celiac and SMA if you're in the suprarenal aorta. Okay, so that's a type 1 and a type 2. So type 2, how do you manage that? Okay, so if you see a type 2, you always coil it? Right, so type 2 is really managed with observation. If the aneurysm sac is continuing to expand in size, that's really the only indication to do something. So most of the time, what you see are type 2s, and all you do is just follow up imaging with those, okay? As long as the aneurysm size is not getting bigger. Okay, so what's a type 3? Okay, so right, this is basically where there's a disruption or a tear in the graft, or in some cases where they do basically multiple modules, so that they'll have multiple grafts put in. So let's say there's one graft that's put in, which has, typically the way these grafts are put in, there's a limb, there's one limb as well as the aortic portion, and then the second limb is typically put into it. So if there's a disconnection at any of those connection sites, that could then lead to a type 3. And then what's a type 4? So type 4 is basically kind of this fabric porosity. You're not going to see that too much now. There was a time when they were actually making the fabric porous. So generally that's something you would only see within 30 days of the acute intervention, because those fabrics were supposed to then become non-porous over time. So you're not going to see type 4s very often, but that's basically porosity, so just blood flow through or plasma flow through the fabric of the graft. And then what's the type 5? Type 5 is endotension. What does that mean? Basically, it's kind of a wastebasket term where you can't find an endoleak, but there's increased pressure. So the sac is expanding, but you can't figure out a reason why. That's called a type 5 or endotension. So most common ones that you're going to see are really type 2. Okay? If it's a type 1, you need to call the vascular guy right away, and then you take them back. Type 2, you just manage them. So if we go back to this case, what type do we think this one is? So main thing what you want to look at is it originating at a proximal or distal seal zone, right? So again, if you look, these are the hooks at the top of the endograft right here, and then this is the body of the endograft, right? So we don't see anything here at this level, right? So the proximal seal zone looks fine. In fact, it's all thrombosed off. It's only when you get down to here. Now the question is, follow this and see if you can actually see, does this communicate with a branch coming off the aorta? I don't know how well it shows up on the big screen there, but on my screen you can see actually very nicely there's one branch coming off right here. Right, so obviously this is anterior, so it can't be lumbars. But this actually is the IMA right there. and this pool of contrast seems to be communicating with the IMA itself. Okay, and then as we go down further, you can see the distal seal zone, because this is all still graphed, right? And then you can see the distal seal zone is not an issue because there's no contrast down here. So in fact, there's basically in the middle of the graft, and it looks like it's communicating with the IMA, so this is likely a type 2. The other thing that we'll do oftentimes with these endograft cases is we'll do what's called a time-resolved angio, so you actually get a series of angiograms as you're giving the contrast, so you can try to see how quickly does this fill. If it's a type 1, you should see it filling with contrast fairly early on, whereas the type 2s are going to have much more delayed filling because it's really retrograde from the, from the lumbars or the IMA vessels that come off. Okay, so again, the key take-home points I think are being able to differentiate a type 1 from a type 2 because those are the most common ones that you're going to see. And then secondly is making sure that you get reproducible measures of the aneurysm sac to see if there really has been any change in size. And then in this case, since this was a type 2, we manage it medically. This was February when I showed you the first scan. This guy came back for a follow-up scan 6 months later, and take a look at the aneurysm sac at this point. And it's a little bit dark on the screen here, but in fact, you no longer see that pool of contrast that we saw before. So, and the size actually, if you look at it, also looks smaller. I don't know if you can see it that well because it's dark, but if you look at the size of it on my screen, I can see very nicely. The size is actually quite a bit smaller than before as well. So this is what we consider a successful result. Now, even though you've got complete thrombosis, the aneurysm sac, you still need to follow these people up over time. Okay.
Real quick. So this is a patient who come. I mean, some of them you probably don't know because I presented this case several years back. It's a patient come here for TAVR evaluation. So basically, this is just a real quick rundown of axial images from the thorax all the way to the pelvis. Tell me when you see something unusual. The clue is when we stop and go up and down. There we go. Okay. So anyway, so real quick. So this is a 3D reconstruction. You can see right here. This abnormality right there, right? The little area that's usually the peripheral vessels are very symmetric. It's amazingly how symmetric they are. But this is definitely, so essentially, I'm going to skip this. You know, obviously you need to do all of them. So this show you the pseudoaneurysm.
The question is, what do you need to call or who do you blame?
Yeah. Well, this study was done in other hospital here in medical center. So it's not done here in Methodist. True. South of us. So. Okay, so this is ultrasound. Okay, so Rob, this is a question. Okay, so this is without color. Okay, so this is pseudoaneurysm. I think this is very. Sorry about that. I'm going to play one more time. Yeah. If you could, huh? Yeah. So Rob, what's your question? Which one? Pepsi sign. Very good. All right. So what do you do? Send the fellow back to put there for another hour?
How big is it?
It's big. Big.
I mean, a bit of size cut off right for like less than 3 or 5.
Well, you saw the 3D reconstruction, so
Do a thrombin injection, but if it's bigger than that, then you send them to the lab.
yeah. So
It always just be compression first, right?
well,
Thrombin injection could be something that you can do.
I can show you the last cell. Basically, so you can see the needle, and this is where it's injecting thrombin. You see you get more smoke. This is the color, much less impressive. And then those are clot. Usually you don't want it, but this time for this kind of situation, it's good. Now the clot, you can see the fibrin, and this is the final result. I don't think it's, but it's pretty good. Okay.
Is there the same jet or no more?
Well, this last clips, I didn't see
I
any.
see something there.
Yeah, there's some blue here. That's right before, and then this is the final one.
Did it just that jet out there?
No, they injected thrombin. Yeah. So basically, this is called like hematoma. Obviously, in continuity with arterial lumen, blood flow in and out, in systole and diastole. And usually because the fellows fall, we're not compressing long enough. So usually the old management strategy is obviously surgical management, especially if it's close to an anastomosis site because of the potential complication of injecting thrombin into the vessels. If you get enlargement rapidly, posterior ultrasound, or it's causing skin so big and so much tension, it causes skin necrosis. Obviously, it's infected, and we feel less invasive procedure. The major concern, if you don't treat it, is could eventually rupture because of the pseudoaneurysm. Minimal invasive procedure is direct ultrasound-guided compression, which is not recommended because it takes a long time. Do you see how deep this thing is with the pseudoaneurysm in between? It's very hard to compress exactly where the entrance side is. Okay, different from just fresh out after arterial puncture. You have direct access where the puncture site is. You can apply tension, but with already pseudoaneurysm forming there, it's very hard to put together. So anyway, so it's really not recommended, and nowadays the real treatment strategy is the local injection of thrombin or collagen into the cavity, which has a much higher success rate. Okay, and in one series of 250 patients, success rate is extremely high. As my wife mentioned, if it's less than 2 centimeters, you can kind of watch it, ultrasound. But if it's getting bigger, you probably need to take care of it. Okay, that's it.
That's great. Thank you, guys.